Welcome to hell. I mean OB and neonates. Pregnancy. It's a 9-month, 40-week period in which a fetus develops inside a woman's uterus, and it's divided into 3 trimesters, corresponding to developmental stages. This is just an overview for my own understanding, and this is the anatomy of the female reproductive system. So there's no need to cover that. Moving on. Labor. It's divided into 3 stages. You'll notice in the ALS it says under the indications that the woman must be in stage 2 of labor. That's because this stage is when crowning or signs of imminent birth and delivery occurs. And most of this slide is more or less review again. So let's move on to our OB/GYN interview and assessment, the relevant stuff. Alright, so you arrive on scene and your patient is female of childbearing age. This is how I typically structure my approach to obstetric patients. So unless it's obvious, that's what that is. There's no point, obviously, to ask if you're pregnant or if you've missed your period. That's all assumed. So from there, you can jump straight in to how far into your pregnancy. So if you want to determine the gestational viability, expected due date, if they do know. How many babies? Is this your first kid? And if this isn't your first kid, if it's your second, third, what have you, how were they delivered in the past? And the reason why that's important is, let's say your patient reveals that this is their second child, and the first child was a C-section. So why is that important? Well, because if all former births were by C-section, then that means you don't know if the baby can actually pass through the birthing canal. You don't have this successful former reference. So it's just something to think about and perhaps aid you in your working diagnosis. That is, if you want to deliver here or if you want a GTFO. Alright, other things to consider. Any complications? So latest ultrasound. Do they know it's a breech? Do they have a history of complications? So C-section. And currently, vaginal bleeding, bloody mucus, or foul meconium discharge. So if their water broke, any discoloration, any foul odor, and of course the all-important pain or contractions. So the reason why that's important is because, well, what are contractions? It's when the muscles of the uterus tighten and relax in a wave-like sequence. And this is important because just like your OPQRST assessment, your pain assessment for an ischemic event, we want to differentiate this type of contraction from what's called false contractions or Braxton Hicks contractions, which are more intermittent and unchanged in duration, doesn't increase or in intensity, and it usually doesn't get better or worse. And most importantly, it's not accompanied by cervical dilation. Whereas true contractions, they do increase in intensity. They typically involve the whole myometrium, or in this case, presenting as entire abdopain. And most importantly, accompanied by cervical dilation, which we cannot assess, but again, something to think about. Alright, so that's our current and our historical interview. Now we move on to our assessment. So again, maintaining patient dignity, get them to a secluded private area, most likely they're at home anyways, and just let them know that you're going to have to visualize, and once you do, this is what you're going to see. It's not labeled, of course. So again, OPQRST, true contraction should be increasing pain in the back, lower abdomen, perhaps the pelvis, thighs, lasting 2 to 3 minutes every 5 to 15 for about an hour. Getting worse. And strength. You can assess for this by placing your fingertips at the top of the fundus. So the fundus would be the top of the uterus. And you're feeling for tightness of the muscle at peak contraction. So if she's screaming, feeling, oh my God, uh, contractions. This is the time to assess for that, and palpating to feel for tightness because it is a muscle. And uterine height. So if the fundus is at the umbilicus, so right here, the belly button, typically that corresponds to 20 weeks gestation. And if the fundus is at the costal margins, up here, typically that corresponds to 36 weeks. And according, or as per the BLS, you want to document the uterine height and fetal movements if you can feel any. Oh, and note that the fundus is the top of the uterus, so it will be where it begins, where the bump or the enlargement begins. So it's not necessarily the highest point. As in, or that is to say, the enlargement of the uterus can begin here, but it might be at its most protruding point here. But you want to measure here, not here. Pregnancy is always reported in weeks. Very important. And one more thing about complications. So it's not just malpositioning, which we will talk about in the next slide. It's also underlying medical conditions that may complicate or make you think that it will be a complicated delivery. So items such as diabetes, drug, alcohol use, smoker, hypertension. And let's talk about hypertension, high blood pressure, which in the context of obstetric patients would be referred to as preeclampsia, which is a sudden spike in blood pressure during pregnancy, whereas so compared to eclampsia, which is a patient with preeclampsia, so high blood pressure during or pregnancy-induced high blood pressure, who suffers a seizure. So when a person with pregnancy-related hypertension has a seizure, it's considered eclampsia. That's another complication we have to worry about. So mild preeclampsia, you might be looking at 150/90, whereas severe might go as far as 160/110, in which case you would have to prepare or at least anticipate eclampsia or a seizure. Alright, let's move on to our obstetrics decision making. So on the topic or extension of complications, the reason why these questions are important is because in all cases, except for scenario land, we have to decide, are we delivering on scene or can we transport? So complications. Let's start with the good. Am I delivering on scene? Signs of imminent birth. Crowning, it's coming out. Bloody show or the water is broke. That's like a ticking time bomb. Contractions, 151, which means one contraction every 5 minutes for about an hour, although this could vary widely. Cramping, enough to impede ambulation. Oh my God, I can't walk. It hurts too much. Urge to move bowels. I feel like I'm about to shit my pants. Patient says the baby's coming. That's the big one. Patient knows more than we do. If any of these signs are present, attempt to move to the ambulance for delivery in there. If you can, this actually should have an asterisk. If you can move to the ambulance, attempt to deliver in there because there's more resources and you have the option of leaving scene whenever you feel it's necessary. But of course, they're probably at home, and if there is cramping enough to impede ambulation, chances are you won't be able to bring them to the back of your truck. So that's the good stuff. Now let's talk about complications. So lack of progress, that's the easy one. So say you have all the signs of imminent birth, but birth does not occur within 10 minutes. You're not going to stay on scene forever, so we're going to have to make the decision to leave. Preeclampsia, as we talked about, assumed in greater than or equal to 20 weeks gestation. So the reason why that is significant, not only because the fetus is deemed viable at that stage, it's also because this is typically the point, the gestational period, in which pregnancy or high blood pressure during pregnancy high blood pressure can be attributed to pregnancy, whereas let's say you are 10 weeks in and you have high blood pressure, it's most likely attributed to pre-existing conditions that elevated your blood pressure, not the pregnancy. In other words, it's more likely that it's not pregnancy-induced high blood pressure if it is under 20 weeks. Nonetheless, 20 weeks gestation with BP 140 over 90 or diastolic BP over 110. Nuchal cord, when the cord wraps around the baby's neck. Cord prolapse, when the cord drops and presents first. So in that case, the fetus would be lying on top of the cord, and as dumb as the fetus may be, it can't relieve or self-relieve its lifeline. So we're going to talk about this, but you can imagine if the fetus is lying on top of the cord, it's suffocating itself. Vaginal hemorrhage, antepartum, so that would mean bleeding before delivery, or intrapartum, indicative of these three. So placenta previa, when the placenta blocks the vagina and presents first. So most of the time, if we go back, well, I guess I don't have a good picture. There's the placenta. If that was down here, you can imagine that it would present first, and that might cause vaginal bleeding. Placental abruption. This is not good. So that's when the placenta separates from the uterus before birth. Excuse me. So the baby should be delivered before the placenta. Uterine rupture, when the uterus itself tears and it allows fetal protrusion into the abdomen. That's very no good. Breech delivery, so these are our malpositioning. So breech, feet first, baby is upside down. Transverse, the arms present, so the baby is sideways. In that case, the uterus externally might present wide, not tall. Occiput posterior, so it's facing backwards. Remember when the baby is delivered, which we will cover in the next slide. The face should be facing backwards. In other words, in this case, it's facing forward, so it's face up, looking up at you. That's called OP positioning. And shoulder dystocia, so the shoulders are stuck during birth. That one's not too bad. Okay. So we're here, or actually it could be any of these. Signs of imminent birth, normal birth, complication. Either way, we want to discourage pushing in on this side, but sometimes it's inevitable. Sometimes the birth is imminent, in which case, okay, we're going to have to make the decision to deliver here on scene. So let's prepare for that. And after we make that decision, let me zoom this back, okay. Don PP, call ACP. Easy way to remember. We want to move the patient to a secure area. Not only that, but we want to get them into the ideal position to look like that. So lying supine on a hard, flat surface, not going to be comfortable. Legs slightly flexed and the head raised. That's for comfort. And of course, we want to obtain and set up our OBS kit. So what's in our OBS kit? Well, we've got sterile scissors for cutting the cord, disposable towels, sterile gloves, clamps for cutting the cord or clamping the cord, a couple blankets, you can never have enough, to receive and dry the baby, gauze sponges to control postpartum hemorrhage, which we will get to, antiseptic towelettes just to clean up all the juices, alcohol prep pads because we always carry those, maternity pads, placenta bags to actually hold the placenta once it's delivered because it's not going in the compost and the mom isn't going to cook it. Twist ties to actually close the bag that holds the placenta, disposable apron, more PPE, a drape sheet underneath mom, scalpel in case our scissors don't work for whatever reason, and a bulb suction, and everything else that we have in our bags. All right, so we've taken a look at the OBS kit, and now we want to put on PPE. Drape the sheet. So the blue sheet, that's the sterile one. That would be right under here, in the image here. Scissors, scalpel, clamps, suction on one side. So when we set up our OBS kit, we want to be strategic with it. So everything that we need to manage the cord and the placenta, we'll put together on one side. And gauze pads, maternity pads, swabs on the other for postpartum hemorrhage. Reserve space for placenta bag and twist ties. Lots of towels. Remember, one to dry off the baby and the other to make a baby burrito and to warm it. And most importantly, we need to set up a station for resuscitation, which will happen. That means assemble a BVM with a pediatric mask, get the bulb suction, and have the cardiac monitor ready with the 4 leads applied and SpO2. All of that we're going to talk about. So OBS is just like a VSA. We want to manage and have everything ready so we're not scrambling to assemble things when we need it. Essentially, in all calls, obstetric calls, we have 2 patients. So management of our scene, resource utilization, communication, all that is absolutely critical. All right, so we have done our interview, we've done our assessments, we've made the decision that we will be delivering on scene. We've prepared for delivery. Let's deliver. So the delivery of the baby, I'm sure we've all reviewed our manuals and taken notes in lecture, so I won't be going into too much detail about the cardinal movements of delivery, but this image panel here demonstrates all of that. For the most part, the woman does all the work. We are there, well, our best skill after assessment would be communication, not just to our team, but to the mom herself, okay? So communication. We want to encourage pushing, push, like you've been constipated for a year, but we want to push with contractions, not between. We want to use every aid possible to get this baby out. But let's start at the beginning. With one hand, we want to guard the perineum, so that's the area between the vagina and the anus, right around here. Or sorry, right there. And as the head crowns, with the other hand, we're going to apply gentle pressure to the head. We're not tugging, we're not pulling, and we're certainly not pushing. That's the mom's job. And we're not also pushing on top of the uterus to help the baby. We're supporting the head like so as it delivers, and we're going to allow for restitution because when the baby descends into the pelvis, it rotates, but the head will present as it crowns face down looking forward, but it has to realign with the sideways shoulders, so it will undergo restitution and realign itself, which then allows the anterior shoulders here to deliver, followed by the posterior shoulders, and then everything else will be a smaller angle, so birth should be spontaneous after that, no problem. So we support the head as it delivers, allow for restitution, and then spontaneous realignment of the head. Encourage mom to take a deep breath, like you're going for a 1 rep max, or many 1 rep maxes, and push with contractions. Take the verbal abuse and instruct her to push like you've been constipated for a year, because we all know what that feels like. If delivery does not occur within 10 minutes, consider transport. That is considered, so the reason why that's here is because that's considered a complication. We cannot stay on scene forever. All right, that's delivery. That's delivery. The baby's born. This is when the panic starts, or this is when the sweat starts dribbling from our forehead. Baby's out, we start a timer and document all notable activities. So at 15, 18, or wherever whatever time it was, at X time crowning was present, and at X time baby was delivered in full. We want to assess immediately for TTC, not the subway transit, but actually, in fact, term tone crying. So, do they appear to match with their gestation or term gestation? Do they have good muscle tone? And are they crying? Note, this is not the APGAR, which we will talk about. This is like your essential. It's like your AVPU versus your GCS. If you can imagine, this is your AVPU and this is your GCS. Actually, that's exactly that, because GCS also has a score. Anyhow, TTC. If yes, we're supporting, so we're warm, dry, stimulating. So provide a hat, warmth, dry in a towel, because remember you have 2 towels, one to dry, and then one to wrap and baby burrito. And suction airway as needed. Remember to suction the mouth, not the nose. Conduct initial assessment, TTC. And as soon as they're dry, they've been warmed up, we can start assessing for vitals. So at this point, I would delegate my partner to place the SpO2 probe on the right hand, which we'll talk about, and the foreleads. Whereas I'm auscultating for an apical heart rate, so I'm going right over the chest on the left side and listening. And I'll typically listen for 6 seconds, and I'll tap with my finger and let my partner, unless they're busy, or let someone count how many. So I would tap for every heartbeat that I hear, and they would be counting. So in 6 seconds, I get X beats, and then I would multiply that by 10 to get my heart rate in 60 seconds. Because it would be difficult to palpate a pulse for a newborn. Alright, and then after that, let's say all is well, all is dandy. We allow the mother to cradle the baby for temperature regulation, skin-to-skin contact, for the letdown reflex, for suckling, and also to promote our next step, which is to deliver the placenta. But nonetheless, after that, we got to clamp and cut the umbilical cord. So our first clamp is going to be 10 centimeters from the baby, not from the mom. 10 centimeters from the baby, so baby might be here, 10 centimeters later, clamp 1. Clamp 2 is 5 centimeters away from the first one, or 15 centimeters away from the baby. So between 10 centimeters and 5 centimeters away from that, you can cut anywhere. And then at this point, we can take our first APGAR assessment. So we take 2 APGARs, one at 1 minute, and our second at 5 minutes. Not a fan of the APGAR, but unfortunately it's there, and it's a universal scale, so we will be discussing it. I hate the mnemonic, but appearance, pulse, grimace, activity, respirations. The reason why I don't like it is because for crying, or rather for grimace and respirations, they both involve some sort of cry. You can read everything on screen here, but it wouldn't be uncommon to have a low APGAR score to begin with at 1 minute, but at 5 minutes we want to see the trend of improvement. At the births that I've seen at clinicals at L&D, when the newborn was delivered, the APGAR was pretty much 0 all the way through. The baby was mute. It looked floppy. It was very blue. It looked purple almost. It was very, it's as if your finger was soaking in a hot tub for an hour and you took it out. But then within 1 minute, almost to the dot, it became, the baby was APGAR 10 all the way through. It just went from 0 to, which is why it's important that we take our APGAR at 1 minute, not as soon as it's delivered. So it does account for that. Okay, pulse oximetry, so our SpO2, in the ALS it says preductal, so the reason why, or what that is. Or actually, let's start with our SpO2 target value. So at 1 minute, not immediately. At 1 minute, we are looking for an SpO2 reading of 60 to 65%. And then at 2 minutes, 65 to 70, and 3 minutes, 70 to 75, and it goes so on and so forth. So the reason why that's there is because, an easy way to remember that is it's just for every minute that passes by, the SpO2 should be increasing at an increment of 5%. Okay, so the reason why the SpO2 is referred to as preductal and why it's on the right hand is because before a baby is born, so in utero, the ductus arteriosus, it connects the aorta, so blood leaving the body, to the pulmonary, or blood leaving the heart towards the body systemically, to the pulmonary artery, so blood leaving towards the lungs. Now, except the fetal lungs aren't developed yet, so blood is just shunted through this circuit, the ductus arteriosus, until delivery, where the first few breaths of life signals the closure of this channel. So the lungs, the fetal lungs are filled with fluid. That's why we have the suction nearby. That's why they cough. When the alveoli open up, all the fluid is released. They have to cough that up. So the ductus arteriosus that connects the aorta to the pulmonary circuit, it closes off. But the ductus arteriosus, it's not immediately off the aorta, but it exists right after the right branch that opens up into the brachiocephalic artery. So oxygen saturation on the right side captures the most accurate saturation reading, since the other arterial branches of the aorta are subjected to the shunting mechanisms from the ductus arteriosus. So that's a big mouthful. All that to say, if we look at the aorta, it looks like, let's see if I can draw it. The aorta has 3 branches. The ductus arteriosus, oh my god, that's horrible. It's somewhere here. It doesn't look like that, but it's after the first branch, but before the next 2 branches. So that would go into the carotid, that would go on to the left side. But the right side is before the ductus arteriosus. So all the blood that goes this way to the right side, so it perfuses the right superiorly and inferiorly, that's unaffected by the shunting mechanism of the ductus arteriosus, whereas these two are. So if you took an SpO2 reading on the left side here, some of the blood will not be as, or it may give you a faulty reading or an inaccurate reading because it came after the shunting mechanism here. Whereas on the right side here, the blood flow happens before the ductus arteriosus. So you will have the most accurate oxygen saturation reading because as soon as blood leaves the aorta through this branch, the right side, it goes straight to the arm and it goes straight to the right side, towards the neck and head. How do I erase this? You don't have to know any of that. Just slap the SpO2 on the right side, right hand. Okay, all that I'm going to skip because we'll talk about it in great detail later on. Alright, so baby's born. Baby's born, we've cared for it. Now let's deliver the placenta. For the most part, we want to be hands-off again, let it spontaneously deliver, and we can help that by allowing skin to skin. But if it doesn't and mom needs a little help, we can guard the uterus with one hand, like so, placing it over the symphysis pubis, and with the other hand we apply controlled cord traction, or we pull on the cord very gently, because the cord, which we've already clamped and cut, it's attached to the placenta inside that still needs to be delivered. Once the placenta is visible, we can let go of the cord and we can actually hold the placenta, because remember, anytime you grip the cord, you are at risk of snapping it off, and that would be a big no-no, because then the placenta would still be inside. So it's a lot easier to grab the placenta and then to grasp, twist, and pull it in an up or down fashion. Document the time of placenta delivery like we do for anything else. And I can say from experience, not me of course, watching it, that the actual birthing process isn't bloody. It's after the placenta is delivered, because the placenta is highly, highly vascular. And as soon as it's ripped off the wall of the uterus, all those vessels, they open up, and you're going to have a gush of blood. It should be less than 500 milliliters. I've seen many textbooks reference 250. Ones I've seen, it looks like several liters. But anyhow, afterwards the placenta is delivered, we want to inspect it for completeness. Otherwise, we can assume that some parts of it may still be in the patient. Let's say the placenta it came out and it's intact. We place in a bag. So after we inspect it, place in a bag, zip tie it, and we treat it like an amputation. So mom's placenta, this time going to this hospital, blah, blah, blah. Okay, let's say the placenta is delivered and the patient is unstable because they're bleeding profusely. We can attempt the external uterine massage, where we take our hand, or use both of our hands, one over one right about here, or a little bit, where the symphysis pubis is, and the other maybe where the umbilicus is. And we push down hard in a smooth circular motion with a cupped hand. So on the lower abdomen, pretty much here, where the umbilicus is. And it's called a massage, but it's very painful. But the reason why we do this for a delivered placenta, and if they are unstable, is because the suprapubic, that's the word, massage helps to expel any remaining placental tissue. And it also allows proper clotting mechanisms to take effect. So let's say the placenta delivers and there's still bits and pieces of delivery or labor material inside. We want to stimulate contractions to expel these intravascular coagulation, small blood clots in the microvasculature, which may prevent thrombin, the actual clotting factors we want, from reaching the bleed. So this is just going to bleed profusely, but as long as we can get a good massage in and promote and actually expel these clots, so we can have the clotting mechanisms take effect. Where was I going with that? Well, also the massage stimulates uterine contractions. So remember, the uterus is a muscle. And like all muscles, they fatigue, they tire, and it's been through labor, it needs a break, but we gotta encourage mom. The hard part's over, but the placenta has not delivered. Let's go for a couple more pushes, we're almost there. So we want to stimulate the uterine contractions to promote muscle tone, and to squeeze the vessels shut to prevent bleeding. So that's what that accomplishes, or attempts to. And of course, like any other bleed, well, we can't shove anything in there. It's certainly not this far up in there to apply direct pressure. But we can do other things: provide warmth, treat for shock, start an IV, blah, blah, blah. That is if the placenta is delivered. If the placenta is not delivered and the patient is still unstable, we will have to attempt the external bimanual compression. Fancy way to say, both hands, one on the left side, one on the right side, and we push inwards. And what we're trying to do is attempt to apply external pressure, just like we would with a bleed. So with one cupped hand on the lower abdomen, one cupped hand above the symphysis pubis, we're closing the uterus. And so how do we know if they are unstable? Well, a couple reasons, or a couple ways to tell. You can estimate how much blood there is. You can take vitals, although I doubt you'll have the time. But the other way is you can assess for fundal height. So if we go back here, that's with the baby inside. If the baby has been ejected out and it's still this high, what could possibly be causing the enlargement? It could be the bleeding. Things to consider. So overview, if the patient is stable and the placenta is delivered, we're all good, normal. If the patient is unstable and the placenta is delivered, external uterine massage. If the patient is stable and the placenta isn't delivered, we can attempt the controlled cord traction. And if the patient is unstable and placenta is not delivered, we're going to have to transport CTAS-1 external bimanual compression to close the uterus off from the outside. Okay. Whoops, what just happened? Okay, right here. All right, bad news. Baby has been delivered, but baby is not doing too well. So we talked about up here, APGAR at 1 minute. So same thing, it's just a continuation. So baby has been delivered, term, tone, cry. Let's say they've got good term, they're 37, 30 weeks, whatever. They look like whatever their gestational age is. Good muscle tone, or actually no, they might not have good muscle tone. Let's say they're not crying either. Okay, they look like they're good term, but they're not crying, they're not wiggling around. Maybe perhaps because they are just getting used to the world. They just came from a nice, cozy, floaty jacuzzi. Let's warm, dry stimulate them. So we do that as our first 30-second primary intervention, warm, dry stimulate. And as we're doing that, our partner can get our cardiac monitoring 4 leads and SpO2. And let's say they're now warm and dry, partner's doing that. Let's get our first ABCs, 10-second apical heart rate and rest rate. All right, so we know what happens if they're good. Then we can hand over to mom. Congratulations, it's a baby. It's a baby. But let's say it's not doing so good. So after we took our apical heart rate and rest rate, or just respirations for 10 seconds, we determined that either one, so heart rate is under 100, so you get less than 10 beats in 6 seconds, or they're not breathing. Any one of those. Or in other words, if it's anything but heart rate over 100 and breathing, if it's anything but that, then we have to do our first critical intervention, which we will start with by initiating PPV, BVM with room air only. Room air only. It's going to be 1 breath every 2 seconds. Or breathe, PPV. Baby, pause. So breathe, baby, breathe, baby, breathe, baby. Breathe, push, 1 second, baby, breathe, baby, breathe, baby. We do that for 30 seconds. The reason why we go for room air is because the newborn is more susceptible to hyperoxygenation. And the reason why we don't do compressions, it's because most of the time, or what research has suggested, is that a heart rate of under 100 or no breathing is more likely attributed to an oxygenation issue. Or in other words, if we can breathe for them, minimally invasive, then they might just improve. We don't want to jump straight into CPR because they are fragile. So breathe, baby, 1 every 2 seconds, and we do it for 30 seconds. So after 30 seconds, we reassess. Let's say their heart rate is now under 60. So it could have been less than 60 to begin with. So no matter what, it doesn't matter. Don't look at this. We're still up here. No matter what their heart rate, it could be 0, it could be 1, it could be 99. We're going to do BVM with room air first. After 30 seconds, we reassess for 10 seconds. And let's say we get a heart rate of under 60. So that would be less than 6 beats in 6 seconds. So let's say we get 5. Okay, so they have a heart rate of 50. Now we can say, okay, room air BVM didn't work. Let's try being invasive. We're done being nice. CPR 3 to 1. So compression, 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 like that. And then breathe. Compression, 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 breathe. If we are ever at this stage, we attach the oxygen 100% to the BVM. So now we have CPR 3 to 1 with 100% PPV BVM. And we repeat that for 30 seconds. Best practice, after 30 seconds, if they are still here, now we can start thinking about transport, because we cannot stay on scene forever, and of course we are not doing any analyses. Okay, let's say we can't get a good we can't get good chest rise and fall. First thing we do is we check our mask seal. Let's say our seal is appropriate. There's no air leakage, then we want to readjust, troubleshoot. Head tilt, chin lift, sniffing position. So pad the shoulders. Remember, their heads are giant bowling balls. Anything we can to get adequate chest rise and fall. Okay, that's how we troubleshoot that. And so we will continue that all the way to the hospital. There is no tour, there's no analyses, we're just going to have to go. We'll probably have to wait for another crew because mom is also a patient. But let's say they're okay. So that's if they're not okay. If they're really not okay. Let's say they're okay, but their SpO2, their target SpO2 is not where we want it to be. Remember, at 1 minute, we want 60 to 65%, and every minute after that, a 5% incremental increase. If their heart rate is over 100, they're breathing, and it's just their SpO2, we can always consider blow-by oxygen and get it up to our desired SpO2, our target preductal SpO2, and remove the oxygen as soon as we're satisfied at where it is. All right. Let's talk about all the other wrong things that can happen during delivery. So all that would be one, so that's essentially one topic. So just as an overview. So our interview, our verbal interview. So current, what made you call today? Historical pregnancy focused. Our physical assessment, which would give us enough reason to make a decision to stay on scene and deliver, or GTFO. In either case, whether they're complicated or uncomplicated, if there are signs of imminent birth, we're going to have to deliver, in which case we prepare for that. We deliver the baby. We care for the newborn. If they're dead, we manage that. So that's all if we have a normal delivery. But we have to consider complications. Remember how we mentioned here, even if the birth is anticipated to be complicated, and if there are signs of imminent birth, we're going to have to deliver a complicated baby. So that's what we're going to talk about here. All right, one of many things that can happen, but these are the common ones that we might encounter. Shoulder dystocia. It's when the shoulders are stuck. So everything else is fine, it's just the shoulders. They've been lifting too much inside the womb, and now their broad, bolder shoulders are stuck. So first we bring mom to the edge of the flat surface, if we can, if they're on a bed. If not, we're just going to have to manage as is. Encourage spontaneous delivery unless it has not occurred after 8 minutes following turtling. Okay, what does that mean? So we drop the time to 8 minutes because 10 minutes is generous. That's for an uncomplicated birth. So 8 minutes, that's why we bring it back. Turtling, that's when the baby presents. So it's like crowning. Baby's head comes out but retracts against the perineum as it's stuck. So it like gets sucked back in. Like, nope, I'm not doing this. If that happens, that will be a signature sign of shoulder dystocia. We attempt the McRoberts maneuver. So that would be to hyperflex the patient's knees to chest to increase the passage angle. So we were here before. Now we want to bring that all the way up here. And the patient can't do this alone, so we're going to have to delegate the spouse or a partner to lift both feet and push it up against the chest. So we're really trying to increase the passage angle here. Knees to chest, hyperflex. So up, out, and wide apart. One person is stuck there. The other person, probably you, will be applying manual suprapubic pressure. So while that's happening, someone is pushing here, just like that. We're putting pressure on the symphysis pubis to push the baby's shoulder down. So these two things are happening simultaneously. If this does not work, we roll over and we attempt the Gaskin's doggy style maneuver. That's just what I put. It's called the Gaskin's maneuver. In other words, they go on all fours, and ideally this is when we want to have them to the edge of a flat surface because we want to allow gravity to help mom deliver the baby. If this doesn't work, we manually deliver the posterior arm. So we reach in, we follow the anatomical humeral joint. We find the wrist of the baby and we bring it so the wrist or the arms of the baby would be curled in. We find the wrist and we bring it back over the head as if it was raising its arm above its head. That's what the manual delivery of the posterior arm is. We do that to create a smaller shoulder angle, and we do it to the other arm, and we're essentially going to have to manually deliver him. And we encourage spontaneous delivery, so contractions, or we encourage pushing all the way through. So that's shoulder dystocia. Breech. Breech is bad. That's one of the malpositions that you may find or that the patient may be aware of during their last ultrasound. So they might be aware that the baby has been breached, in which case they would be at a hospital anyways. But anyhow, let's say the feet presents first and it's not coming out. The protocol here is to be hands off until the baby has been spontaneously delivered to the umbilicus. The reason why that's there is because if we put our hands on the baby while it's breached, then we might stimulate spontaneous respirations. Remember that when a baby is born, and we get our hands all over it, it would want to take its first couple breaths of life to activate the lungs. But the baby is still inside. So if we touch the baby and we stimulate spontaneous respirations, it might encourage the baby to breathe while it's still inside mom. In which case we have risks of aspiration and all sorts of things. Anyhow, hands off until it's born to the umbilicus. So until we see right about that part of the baby. So spontaneous delivery until the umbilicus. As soon as that's been done, we have a 3-minute timer to either spontaneously deliver the rest of the baby or until the nape, the hairline of the neck, so that would be right here, right there, is visible. So let's circle back. Breech baby, feet presents first. Hands off, spontaneous delivery until the umbilicus is born. Once this part has been reached, it's a 3-minute timer. Either the entire baby has to be spontaneously born, or the nape of the neck is visible. If the entire baby spontaneously births, then we're okay. We can be hands off the entire time. If 3 minutes has elapsed and the nape of the neck is visible, then we can attempt the Mariso Smelly V maneuver. So you can remember it as breech, feet, smelly V. Now it's hands-on. What we do, look here. Using one hand, our index and our ring finger would go on either shoulders, and then our middle finger would be supporting the occiput, or the back of the head. That's over top the baby. With our other hand, we go underneath and we find the two cheekbones. So our ring finger and our index finger on either cheekbones, and we ice cream sandwich the baby as so. And the Mariso Smelly V calls for a up and down seesaw motion to gently pull the baby out. And then at this position, once the baby has been delivered, this hand goes here, this hand goes over top, and we flip the baby so that it's lying flat on mom. So ideally we have a blanket here ready to receive the baby, so it goes like that. Smelly V. Alright, last but not least, prolapse cord. So like we mentioned before, a prolapse cord is when the cord presents or protrudes outwards from the vagina. So we can assume that the baby or parts of the baby is compressing the cord and suffocating it. So in this case, we have to discourage delivery. We don't want it. We don't want this complication to deliver. And how do we do that? Well, first we say don't push, and then second we encourage panting. This patient needs to go to the hospital, level 3 birthing center, ASAP. So how do we manage that? Well, first we roll the patient. So actually this position is called the exaggerated Sims position, where we roll the patient to the left side. We have the left arm here, reaching over the head, the right arm reaching back. Her right leg is hyperflexed, knees to chest, while the other leg is flat. So it's like a recovery position, but with more involved. That's the exaggerated Sims position. It's a safer position to transport, and the reason why we do this is because so that we can insert one of the only times we can insert our fingers into a body cavity or orifice. We insert the gloved fingers of our left hand into the vagina to apply manual elevation to relieve the baby's weight off the cord. So if the baby's head is pressing up against the cord, we'll have to squeeze our fingers in between and cushion the baby's head so that the cord can resume pulsations. As you can imagine, whoever is doing this, probably you, is now stuck here until transfer of care at the hospital. The reason why we use the left hand is because if you can imagine in an ambulance, the way it's situated, the way the stretcher, it's on the right side, or the left side of the ambulance, but it's on the patient's right side. So if we use our left hand, we'll still have access to all the cupboards and resources using our right hand. And it doesn't matter what handedness you are, this would apply. Alright, last one. Nuchal cord. The baby tries to hang itself. So if the cord is present and it's loose and it's around the baby's neck, we can just simply slip it over the neonate's head and discourage delivery, unless of course it's imminent. But obviously if you see it around and it's loose, just slip it over. If the cord is present, it's looped around the baby's neck, but it's tight, and we cannot slip it over the baby's head, we clamp and cut the cord. As soon as we clamp and cut the cord, we have to, so clamping and cutting the cord would relieve the cord from suffocating the baby. But as soon as we ever clamp and cut the cord, we have to encourage rapid delivery, because now the lifeline of the baby has been disconnected and the baby needs to come out. So that's how we manage medical complications for birth. Let's talk about traumatic complications. All the things that can, well, many things, but generally speaking, premature labor, it's not traumatic, but you might see rapid contractions. Spontaneous abortion, placenta abruption, uterus rupture, may see vaginal bleed, abdominal back pain, tenderness, enlargement. Diaphragm rupture, because it's naturally when you're pregnant, the uterus would push up against the diaphragm, so you're more susceptible to pneumothorax and barotrauma. Shock, hypoxemia, obviously because you have more blood shunted towards the uterus, and you have elevated hematocrit levels, elevated heart rate, blood pressure, all of that. So your hemodynamics will be elevated for the duration of pregnancy, typically during your third trimester. We suspect a lot of these for MVC, deceleration injury, because of with MVCs you're worried about a sudden deceleration against the stationary object, such as your seatbelt, that's across your lap. And obviously blunt abdominal trauma, so direct trauma to the abdomen. Pelvic fracture, accompanied or often seen in an MVC. And because the pelvis is where the baby descends into for second stage labor. Domestic violence, so that could really be anything, but something to think about. Okay, trauma and obstetrics, so that's here. Occult internal injury from minor trauma without evidence of external signs may still indicate fetal trauma. In other words, even if any of these are present and you cannot see it on the outside, so let's say they were involved in MVC, but there's nothing to suggest there is trauma. There's no signs. Perhaps there are symptoms, but there are no signs outwards. Your index of suspicion for fetal trauma should still remain high, because the peritoneum has reduced pain perception during pregnancy, so it might mask internal trauma. So like any other trauma, we treat with O2, oxygen, warmth transport, and we go CTASP1 because, and it's within the BLS, for any vaginal bleed during the third trimester, greater than or equal to 20 weeks gestation, because of everything we mentioned here, and because it's 2 patients with any obstetrics. How do we transport, and how do we manage hypotension in obstetrics? We transport if they haven't delivered, obviously. We transport them in a left lateral position, which we accomplish by performing left uterine displacement. So that's the patient's right side, that's the patient's left side. We displace it, the uterus, to the left side, because that's the heart here. The inferior vena cava actually favors this side, so it runs down this way. It doesn't go centrally downwards. So if we didn't do this, the uterus may compress the inferior vena cava. So if they are hypotensive, before jumping to an IV, we want to consider positional modifications before being invasive with fluids. So this position increases blood flow to the heart and baby by placing a cushion or anything on the right side to pad and tilt the patient to the left side this way, to displace the uterus towards the left side, shifting it off the inferior vena cava, which favors the right side. So let's say you're in MVC and they're on a board. It is completely reasonable to tilt the board approximately 15 to 30 degrees to accomplish left uterine displacement, or left lateral position. Typically, this is for patients who are 20 weeks gestation. 20 is the magic number here. or in the third trimester. So if their fundus isn't at the umbilicus level, which would indicate 20 weeks gestation, you don't have to worry about left lateral position. Okay, that's obstetrics and trauma. All right, this final piece is an overview of everything we covered. And this is, by overview, I mean how the approach and flowchart would typically look like for an OB case. No point to go back in the slides because it's all here. So I divided into 7 steps. So first, our focused assessment, our preparation, and by the way, this covers all the other slides. So focused assessment, preparation, are we going to deliver on scene, presentation, any complications, delivery of baby, delivery of placenta, and then postpartum care for mom, this is baby. And then transport. So let's start here, up here. So this is going to be a review. Interview. So always verbal before physical. So verbally, how far are you into your pregnancy? Obviously, I skipped the steps where we ask if we are suspecting they are pregnant. Let's say they are obviously pregnant. How far are you into your pregnancy? We want to know the gestational age. Is this your first pregnancy? Any complications in your current pregnancy? Any complications in your historical pregnancies? How often are you feeling contractions? Because we want to determine if they are true or false Braxton Hicks contractions. Are they increasing in intensity? How often do you feel them? How long does each one last? Is it 151? Water broken? Any discoloration, foul odor would be indicative of meconium. Which means, so all these suggesting birth is imminent. So all this is to answer this, or this question. That's our interview. Physical assessment, we're assessing for fundal height. Remember, at 20 weeks gestation at the umbilicus, 36 weeks at the costal margins. And ultimately, is crowning visible? Let's say they tick all of these, or most of these, enough to make you believe that you would have to deliver on scene. Don PPE, call ACP, first step. Move the patient to a flat surface or bed if you believe that you would wish to have gravity aid you in your delivery. And we open up our OB kit. As an overview, blue sheet underneath the mom, towels on the legs. Baby gets 2 blankets, 1 to dry, 1 to warm, and a hat. Placenta, we want a station to get ready to manage the placenta, so clamp, scissors, gauze sponge, tie, and bag. Resuscitation set nearby, that includes vitals, so BVM, suction, SpO2, and 4 lead. So now we've conducted our focused assessment. We know she's pregnant. We know there's signs of imminent delivery, so we know, or we have made the decision to deliver on scene, and we have prepared for it. Now let's actually take a look and see how it's presenting, which would tell us if we have any complications. If it's normal, fantastic. Breech, feet, smelly feet. Shoulder dystocia, we attempt the Merck-Roberts. If not, the Gaskins. If not, manual posterior delivery. Cord prolapse, we're going to apply digital pressure with our gloved finger, or with our left hand, and transport an exaggerated Sims. If it's nuchal cord, we untangle it off the baby's neck, off and around, clamp, or clamping cut, and encourage rapid delivery. If it's transverse, as in the baby is sideways and the arms are presenting, we cover protruding limbs, treat as an evisceration, and we have to initiate rapid transport. We cannot manage that. Preterm, so before 37 weeks, we wrap in a plastic bag for warmth, not a towel, because plastic is a better insulator. And that's all our complications. Pray to God none of that happens. Delivery of baby. So the baby has been delivered. Our first assessment is TTC, good tone, or good term, good tone, and good cry. And we dry warm stimulate for 30 seconds. Our partner can take SpO2, 4 leads, and we can take our APGAR. And then we'll determine our heart rate and breathing with auscultation, apical heart rate. Let's say it's good, then we can, if it's good, but their SATs aren't where we want it to be, we give blow-by oxygen. If they're fine, we can just hand it off to mom and encourage skin-to-skin contact. If it's not good, as in either their heart rate is under 100 or they're not breathing, we have to go to our resuscitation table or set and initiate PPV, room air, no oxygen, for 30 seconds, and then reassess for 10 seconds afterwards and determine if it is still heart rate under 100 or they are not breathing. If the heart rate is under 60 at that point, then we can begin CPR 3 to 1 with oxygen. If we cannot get good chest rise and fall, we troubleshoot it by readjusting our mask, attempting the sniffing positions, suctioning as needed, and we continue on with that. Let's say they are now, let's say their APGAR has improved to a full 10 or 7 to 10. We now want to hand it off to the mom. We are satisfied the baby is okay. Now we have to deliver the placenta. Is it spontaneous? Can she deliver on her own? If she can't, well, first we have to clamp and cut the cord. But if she can't deliver spontaneously, we are going to apply controlled cord traction. So one hand on the symphysis pubis and the other hand tugging the cord in a controlled fashion. Placenta has delivered, inspected for wholeness, bag and tag. Now, after the placenta has delivered, we can imagine there's going to be a lot of hemorrhage. Is it over 500 milliliters? If so, and the placenta has delivered, we are going to attempt the external uterine massage. If it has not delivered, we are going to close it off and apply external pressure using the bimanual uterine compression. And this person will now be stuck there to hold that uterine compression until transfer of care is possible at the hospital. And transport. If delivered, we are okay to transport her as any other patient, or she may choose to remain at home and sign herself off. If she is not delivered, we are going to transport her in a left lateral position, and we will be going CTAS 1 to a level 3 hospital if it's complicated. Okay, what a mouthful. That is the end of our obstetrics lecture and neonates. Good luck to all of you. Drive safe, wear your seatbelt, and pray for a successful delivery.